Hello friends, today we are going to discuss questions from NEET PG 2024 on the subject psychiatry. Let's look at the MCQs. So the first MCQ is, which of the following SNRI is used in the treatment of ADHD? As you know, SNRI is serotonin, norepinephrine reuptake inhibitors, right? So which of these is an SNRI used in the treatment of attention deficit hyperactivity disorder? Is it guanfacine? Guanfacine is a drug which is a alpha 2A agonist, and guanfacine is used mostly in the management of opioid withdrawal. So guanfacine is not the answer. So is it methylphenidate? Methylphenidate blocks the reuptake of dopamine and norepinephrine from the presynaptic neuron. So as you know, in a synaptic vesicle, this is the presynaptic neuron, this is the postsynaptic neuron. So when the neuronal firing happens, norepinephrine and dopamine are released into the synapse, and it is after the signal is passed, the reuptake happens into the presynaptic neuron. But what methylphenidate does is, it blocks the reuptake of these neurotransmitters, which leads to persistence of these neurotransmitters in the synaptic cleft, right? So methylphenidate is not having an SNRI like action. So is it reboxetine? Reboxetine is definitely having norepinephrinergic reuptake inhibition. It is NRI, and it also has very minimal action on the serotonin transporter. So it blocks the serotonin transporter or SERT. It also blocks the norepinephrine transporter or NET, right? But the affinity towards NET or norepinephrine reuptake inhibition is about 20 times more than the blockage of the SERT, that is serotonin transporter. So reboxetine definitely has some SNRI like action, right? But is reboxetine used in ADHD? It is definitely used in ADHD. So our answer is C, reboxetine. And what is modafinil? Modafinil is a drug which inhibits the reuptake of dopamine in the synaptic cleft, right? Modafinil is a stimulant like drug which is used in the treatment of narcolepsy, right? And many other conditions, but predominantly because of its stimulant like properties, it is used in the treatment of narcolepsy. So the answer here is reboxetine. It has SNRI like action and it is used in the treatment of ADHD. So moving on to the next question. A child with untreated ADHD, attention deficit hyperactivity disorder, is most likely to develop which of the following disorders during adolescence? So kids with ADHD have vulnerability to develop certain other psychiatric disorders. So we want to look at which is that psychiatric disorder among these options. Is it binge eating? Are they more susceptible to develop binge eating? That is, there is a bout of eating of high calorie foods, right, in these individuals. Definitely ADHD does not predispose for binge eating. So is it selective mutism? Selective mutism is when kids have this behavior of going mute, that is not talking at all, in very selective situations. So for example, a kid is talking at home, but at school he goes completely mute. And selective mutism is seen in anxiety disorders, right? Anxiety disorders. But does the child with ADHD have predisposition to develop selective mutism? No, right? And is it separation from parent leading to depression? So, you know, there is a condition where if you withdraw young children from their parents, they can go into depression, right? But it is not commonly seen, or it does not have a special association with ADHD. So even this is not the correct answer. So the answer here is conduct disorder, right? What is conduct disorder? It is where a child will develop very difficult behaviors, externalizing behaviors, like a child may be seen lying, stealing, right? They may be having aggressive behaviors, they may set things on fire, they may hurt animals, they may be having disobedient behaviors towards authority figures, right? And may end up in lot of trouble at school, may even land up in legal problems, right? That is called as conduct disorder. And we frequently see that kids with ADHD, if they go unaddressed, then it can lead to a chain of problems, ultimately leading to something like a conduct disorder. And also, if you look at the heritability factors for ADHD and conduct disorder, you would see some overlap in the heritability factors and genetic factors. Moving on to the next MCQ, a 39-year-old woman presents with feelings of nervousness. So she's having nervousness, has abdominal pain and diarrhea. She has history of heartburn and indigestion for 25 years. She gives similar complaints in the family of being tense and nervous. So this, feelings of tension and nervousness which pervades throughout the day, that kind of a trait is seen in her family members also. Which else symptom, what other symptom do you expect to see in this condition? So it looks like this individual has an anxious mood, pervasive anxious mood, and that pervasive anxiety is leading to physical symptoms and predominantly gastrointestinal symptoms like abdominal pain, indigestion, heartburn and diarrhea, right? And it has been chronic. So this person is definitely suffering from a chronic anxiety disorder. With this limited information in the MCQ, it is very difficult to ascertain whether it is, say, a generalized anxiety disorder, right? We don't have enough history in this MCQ, but we can definitely know that there is chronic anxiety disorder in this patient. So what other symptom can we expect in this patient? Is it neologism? What is neologism? Neologism is seen in, patients with schizophrenia, where a person attributes a completely new meaning to a known word, right? For example, he may use the word football, but he may mean heart, right? So when he is using the word football, actually he means heart, right? Or he may invent a completely new word which is not in the vocabulary or in the dictionary, right? That is neologism. So do you expect a neologism in a patient with chronic anxiety disorder? No. And is it ideas of reference? When an individual feels that things happening around them have some special meaning towards them, and especially a very negative or a sinister meaning. For example, a patient who has a psychotic disorder or schizophrenia, when he goes out and somebody on the street smiles, they think that they are somebody who is behind them and they are conspiring something against them, and that smile has a special sinister meaning to this individual. That's what we call as ideas of reference, right? Or say an individual watches something on the TV and thinks that the person, the news anchor, is telling something which has a special meaning towards him. That is ideas of reference. We usually don't see that in a chronic anxiety disorder. Is it hallucination? Definitely not, because hallucination is a psychotic symptom. Hallucinations and delusions and catatonic symptoms are positive psychotic symptoms, which is usually seen in psychotic disorder. So what we need to understand is A, B and D are features of psychotic disorders, and we are considering a chronic anxiety disorder in this lady that is given in the MCQ. So the answer is tingling of extremities. Tingling of extremities or other somatic symptoms or physical symptoms are commonly seen in somebody who is experiencing chronic anxiety, right? They may have gastrointestinal symptoms, they may have cardiovascular symptoms such as palpitations or chest pain, they may have neurological symptoms such as headaches, right? Tension headaches, band-like pain around their scalp, or they may have muscle tension symptoms leading to backache, and pulling sensation in your legs, they get easily fatigued if they do little work. Also, they may have these kind of pseudo-neurological symptoms where there are tingling of extremities or cold or heat sensation in the extremities. So, the likely answer here or the correct answer here is tingling of extremities. Moving on, a 22-year-old girl child came agitated to the emergency department after consuming some drug. So, there is history of some drug consumption. She has previous history of suicidal tendencies. The parents do not know the mode and route of drug administered. She presents with tachycardia, tachypnea, increased heart rate, increased respiratory rate, diaphoresis, excessive sweating, dilated pupils. So, there is mydriasis, okay, in this child, right? What is the likely drug administered, right? So, basically this person has history of suicidal tendencies. There is history, past history. So, someone comes in an agitated state or a confused state to the emergency department with a past history of suicidal tendencies. You have to think of a drug overdose, right? So, or consumption of some recreational drugs maybe. So, which are the possibilities? Is it chlorpheniramine? Chlorpheniramine is a antihistaminic drug, right? And will it cause agitation, tachycardia, tachypnea? It may cause drowsiness, sedation, but it is very unlikely to cause tachycardia, tachypnea and other symptoms. Is it morphine? Usage of morphine or overdose with morphine would lead to misuse, right? Morphine is a opioid drug, and you know very well that opioid drugs, when they are overdosed or when there is consumption of opioids, there is misuse or there is constriction of the pupil. And in fact, if somebody comes with an opioid overdose, heroin overdose, they would have pinpoint pupils, which is very classic of opioid overdose. So, heroin and morphine are also not answers. Chlorpheniramine is also not the answer. But cocaine is a stimulant drug, psychostimulant, and if somebody has used it excessively or if they are intoxicated with cocaine intoxication can lead to all these symptoms. They have behavioral agitation, they will have tachycardia, tachypnea, diaphoresis, and they will have dilated pupils, mydriasis. So, the answer here is cocaine. Next question, an alcoholic patient presented to the emergency in an unconscious state. So, this person has come with unconscious state. Relative state that he had an episode of binge drinking 1 week back. So, what is binge drinking? The individual goes on consuming alcohol at certain intervals where the intoxication doesn't come down. So, he will have a certain set of drinks, and before the intoxication comes down, he has another set of drinks, right? And that can lead to severe intoxication with alcohol. So, on examination, so he had a binge drinking episode 1 week back. On examination, his glucose is 49 milligram per deciliter. So, what does that indicate? 49 mg per deciliter. It indicates severe hypoglycemia, right? So, when you see severe hypoglycemia in an individual, what is your first step? You think of giving IV dextrose, correct? That's what is the dictum. But here you have to remember, this is an alcoholic patient. We know very well that in a patient with alcohol abuse or alcohol dependence, the absorption of thiamine, vitamin thiamine is reduced. Also, the stores of thiamine in liver is also reduced. So, in an individual who has history of alcohol dependence and he has binge drink, he had a binge drink 1 week back, in such a fellow, if you give dextrose, right, directly, what can happen? It will lead to Wernicke's encephalopathy, right? So, why does that happen? Because there is a crisis in the body. You know very well that thiamine pyrophosphate is a cofactor in Krebs cycle, right? So, when you push dextrose to this individual, all the thiamine reserve that is there in the body gets diverted towards Krebs cycle all over the body, and there is a deficiency in the brain of thiamine leading to Wernicke's encephalopathy. So, that leads to hemorrhages in your brainstem region and leading to Wernicke's encephalopathy, and Wernicke's encephalopathy, if it is not treated in time, it will lead to Korsakoff psychosis, correct? So, whether you would give IV 25% dextrose, no, you cannot give directly. Will you give IV thiamine first followed by dextrose infusion in this person? This is the correct answer. Normal saline infusion would not treat his hypoglycemia, correct? Also injection vitamin K followed by dextrose infusion, we don't really know whether this individual has any clotting abnormalities, right? So we don't have enough evidence in the MCQ. What he has is hypoglycemia right now, correct? And he is an alcoholic patient. So basically give thiamine, later on give dextrose. Moving on. So the answer is B. A girl was referred to the psychiatry department by the plastic surgeon. So she had visited multiple plastic surgery departments requesting full facial reconstruction. She complains of dark blemishes and spots in her face which are not actually present. So the family members are telling that it is not very apparent, but she insists that there are blemishes. She always says that she is ugly and looks constantly in the mirror. So she is repeatedly checking in the mirror or at the back of the spoon when she is having food or at the windows when she is moving around in a place, right? So she is constantly checking what has happened, to her face, right? Her mother reassured her of no, and that she doesn't have any issues, but she is insisting on getting the surgery. So what should the psychiatrist do? So clearly this person has a perceived, there is a perceived defect, correct? Because the family members are saying there is no problem, the plastic surgeons are saying there is no problem, but this individual has this perception that she has distorted face because of those blemishes and she wants this surgery to be done, right? So what is this condition that this girl is going through? This is known as body dysmorphic disorder, and body dysmorphic disorder, it is a obsessive compulsive and related disorder, OCRD, right? Earlier we were thinking that it is closer to delusional disorders, a psychotic disorder, but right now our understanding is that BDD is very close to OCD, right? That's why it is put under obsessive compulsive and related disorders, right? Because of the repetitive thoughts of having certain defects in the body or in the face in this particular case, right? So will you give fitness for surgery? No. Will you start insight oriented psychotherapy? This person, it will be very difficult for the person to engage in psychotherapy, in a very elaborate psychotherapy such as insight oriented psychotherapy, and this person clearly lacks insight. There is absolutely no insight. So when an individual is completely denying any illness, any problem, psychological problem, you can't really engage them in psychotherapy. So this is not possible. Will you start on atypical antipsychotics? As I already told, our earlier understanding was that BDD is a delusional disorder or closer to delusional disorder, but that has changed. So starting atypical antipsychotics would not be the best strategy, right? It would not be the first line treatment. So the correct answer here is start her on SSRIs, selective serotonin reuptake inhibitors. Like in OCD, BDD, body dysmorphic disorder, also responds to SSRIs like escitalopram, paroxetine, fluoxetine, sertraline, right? So the answer is B. Next question. A 30-year-old male presents as calm and in fact charming in front of a psychiatrist. However, he engages in aggressive behavior towards friends, frequently skips classes, disregards traffic rules, right? And has been involved in a police interrogation. He has gotten into legal problems. What is the most likely diagnosis, right? So what you see here is this person is able to, keep a sense of calm and charm in front of a particular person. So it's very manipulative, right? But when it comes to his friends, he is engaging in very aggressive behavior. He has impulsive and aggressive behavior. He is not attending classes. So whatever social conventions are there, rules, regulations are there, he is breaking them. He is disregarding traffic rules. He is not worried about ending up with legal problems. In fact, the police are interrogating him, right? So what does this suggest? Is this narcissistic personality disorder? No, because narcissistic personality disorder, the most characteristic feature is the individual has a very high image of oneself, right? They are boastful of themselves and they want people to admire them. So it's not NPD. Is it schizotypal personality disorder? In schizotypal personality disorder, the individual would have odd eccentric behaviors, right? Magical thinking, psychotic symptoms. This does not fit. Whether it is paranoid personality disorder, where the individual is suspicious, mistrustful of others' actions, litigious behavior would be there. Is it paranoid personality disorder? No. Paranoid personality disorder and schizoid personality disorder also have a susceptibility to develop psychosis. But our case, it is close to an antisocial personality disorder, right? ASPD, or the other name is dissocial personality disorder, right? In this personality, there is impulsive, aggressive behaviors, lack of empathy, right? In relationships, they are very emotionally cold, right? They can be manipulative, they can break rules, they can end up in a lot of legal problems because of fights, because of stealing, lying, and all sort of legal problems, right? So the answer is A. A man experiences sexual arousal from wearing female undergarments and high heels during sexual activity with women, but he is not attracted to men. So the sexual orientation is very clear. It's not that this person is attracted to men, and also he is getting sexual pleasure in a very deviant way. Basically, he is getting aroused by wearing undergarments of women and also high heels of women, right? So what is the most likely diagnosis? So is it gender dysphoria? What is gender dysphoria? Gender dysphoria is where an individual feels that he is trapped inside another gender's genitalia or body structure, right? So for example, a man will feel like a woman. The person feels that he is a woman but trapped inside the body of a man, right? So there will be disgust towards one's body. This is gender dysphoria. So this person does not have anything like that. What is hermaphroditism? Very rarely an individual can have male and female genitalia or male and female gonads, right? That is hermaphroditism. This person does not have hermaphroditism. This, is it gay disorder? There is nothing called as a gay disorder, right? The option itself is wrong, right? So being a gay is just a different orientation, sexual orientation. It's not a psychiatric disorder. So the usage of the word disorder itself is wrong. So it cannot be the right answer. So the answer here is transvestic fetishism. So basically, this man, he is cross-dressing, transvestism, right? So basically a man is wearing female's clothes and female's footwear, right? And he is getting sexual pleasure out of it, of wearing or cross-dressing. Through cross-dressing, he is enjoying that arousal or sexual pleasure, right? This is called as transvestic fetishism, and it is a sexual deviation, you can say. Next question, which drug is used in the maintenance phase of opioid dependence? I think the correct terminology should have been opioid dependence, right? So there is a acute treatment in opioid treatment, right? Opioid dependence treatment. What is the acute treatment? It is detoxification, right? And what does detoxification entail? Detoxification is basically treatment of withdrawal symptoms, correct? So, but here the question is not the acute phase treatment, it is maintenance phase treatment, right? So what is maintenance phase treatment? All the withdrawal symptoms have gone away now, right? Now you have to ensure that the individual does not relapse into substance use again. So whether disulfiram you would use? No. Disulfiram, what is disulfiram? It blocks aldehyde dehydrogenase and leads to lot of uncomfortable symptoms if a person drinks alcohol while being on disulfiram. So this is used in alcohol dependence syndrome, correct? To prevent relapse. Disulfiram is not the answer. Is it butorphanol? Butorphanol is a opioid analgesic. It's a painkiller, opioid painkiller, right? It has agonistic and antagonistic action on opioid receptors, and it is used in anesthesia, right? But is it used in the maintenance phase treatment? No. It's an opioid analgesic basically. Is it clonidine? Clonidine is again like guanfacine we saw earlier. This is also a alpha 2 agonist, right? And clonidine can be used in the acute treatment of opioid dependence. not in the maintenance phase, because it is useful in managing the withdrawal symptoms, opioid withdrawal symptoms, right? Especially the, tachycardia, muscle aches and pains, right? Sweating, restlessness that can arise when a person is experiencing opioid withdrawal. So the answer here is buprenorphine. What is buprenorphine? Buprenorphine is a partial agonist at the mu receptor, mu opioid receptor. So it's a partial agonist at mu opioid receptors, and it has some action on other opioid receptors also, kappa receptors and all, right? And buprenorphine, its specialty is it can be used in managing the withdrawal symptoms, that is, it can be useful in acute phase, it can also be useful in maintenance phase to prevent relapse. So the answer here is D, buprenorphine. A young girl presents with multiple episodes of loss of consciousness. So this individual is having multiple episodes of loss of consciousness, each lasting about 20 minutes. So about 20 minutes time these are lasting, but these episodes are occurring exclusively in front of her family and only during daytime, right? There is no history of tongue bite, correct, and incontinence with these episodes. So there is loss of consciousness, but it is only happening in front of the family, only during daytime, and there is no tongue bite or incontinence, which is suggestive of true seizures or epileptic seizures, right? And again, EEG and MRI are normal. They have come out as normal. So this individual is very unlikely to have true epilepsy, but they have psychogenic non-epileptic seizures, right? Psychogenic non-epileptic seizures. So something known as PNES, correct? So what is the appropriate management for this patient? Would you treat with aversive therapy? Aversive therapy is disulfiram usage in, say, alcohol dependence, because once the individual is on disulfiram and drinks alcohol, he develops all these uncomfortable feelings or uncomfortable experiences. He will feel aversive towards drinking alcohol. But we don't use aversive therapy here. Will we, start this girl on valproate, anti-epileptic? No, no role. Whether ketogenic diet has any role? No, no role in PNES, psychogenic non-epileptic seizures. So the answer here is insight-oriented psychotherapy. That is, we need to understand why this individual is developing these dissociative symptoms, the dissociative convulsions that this individual is having. What are the psychological factors that this person has, right, which is leading to such symptoms, right? And that can best be done by using a insight oriented psychotherapy, where you look at the individual's past, right? It may be immediate past, last few months, it may be last few years, or it may be something related to their childhood. Like imagine a child has experienced sexual abuse at a very young age. As an adult, that girl may develop these dissociative convulsions, right? When anything reminds her of the abuse or anything triggers her, they may develop dissociative convulsions. So insight oriented psychotherapy may be helpful in these cases of dissociative convulsions. With that, we come to the end of this session. Thank you.